managed care will succeed. It will succeed if it facilitates communication between patients and their caregivers. So you can tell if it's going to work, and you'll be able to tell pretty soon. At our session this afternoon, we already talked about some cases where it was working and some where it wasn't. Managed care will clearly fail if it cannot improve on the existing relationship between doctor and nurse and patient. Now, the existing relationship is not that great. Let's not idealize it. But it can get worse. And if that happens, managed care will slowly fail. And the reason is because of the additional hassle and paperwork and bureaucratic parsimony and the appearance that this is a low-touch, low-tech system when Americans like high-touch, high-tech. Because of these factors, if it appears to be that managed care is like that old CAT scan joke where they take out, you want a CAT scan, they take out the cat and run it over your body. These jokes, of course, have this hard edge underneath that, we'll start reading about managed care in Reader's Digest, like this last issue, a Milwaukee case of a woman whose CAT scans were, whose Pap smears were misread for 3 or 4 times and turned out to have cervical cancer. And they attributed it to poor quality readers. Now, communication problems are ubiquitous in medicine right now, so I think we should first, to see what managed care really means to doctors, and I think to the patient, we should look and see what communication occurs now. I once saw a Wisconsin farmer who at age 72 was severely bow-legged. He looked like he'd been out riding horses. He had hypertension, he had a detached retina, and surgery was scheduled for that very day. But the question was, should he have a scleral buckle, which is they put it around the eye and kind of tighten it, or should they inject air, and that tries to put the retina back on with air bubbles? Turns out this farmer had no running water in the house. He lives alone, and he has to make all his own meals. If he had the bubbles injected, he'd have to lay face down for several days. So that's just impossible for this particular patient. It can't be done. Now, a few minutes spent listening to his life situation demonstrated that he needed this scleral buckle. But you know what the patient told me? He said, doctor, I don't know what I should do. They told me I could have this air thing or this buckle. And he's agonizing over this decision. His eye doctor had left the decision to him, but this is not fair. This is not right. So unfortunately, there seems to be a wide variation in the individual physician's ability to interact effectively with patients. Why is it that when you have 3 residents working with you, some people have a 75% show rate of their patients, some have a 90, and some have a 30? Why? Some apparently successful modern physicians would have failed miserably in the past. They don't seem to know how to talk to people. Without their chosen technological procedure, they would actually be therapeutically useless. They would actually be impotent. They lack the common touch. They don't know how to be helpfully present with people, and they don't know how to use the power of words. And we, of all people as Christians, should know the power of words. There's another group of modern physicians, I think just by luck, just they're attracted to it, this area too, who would have been fine doctors years ago, and they can now employ both their useful words and their useful technology. Now, both kinds of these doctors can establish practices, and they can perform surgery, they can reattach retinas, and they can teach students and house staff. And both kinds are going to be in managed care organizations. But only those who are sensitive to the patient's meanings within the discourse of medicine, who try to provide respectful treatment, who talk to patients, will be successful in their encounters with patients. And only those managed care systems which kind of foster this and don't beat it down will succeed in the long run. What's the long run? Maybe 10 years. If we agree that this kind of treatment has always mattered to patients, then let's be fair. Let's not say that the problem is managed care. Let's say the problem is the doctor or nurse doesn't talk to me, they seem in a hurry, they seem to have other things to do. And let's say that That's maybe been a problem in fee-for-service. According to Bill Clements, American Medical News, good communication could save $210 for each unneeded emergency visit, $85 to $115 for each unneeded specialty referral, $20 for each unneeded office visit. And a recent study found that only a third of patients who were given prescriptions took them exactly as the doctors wanted, and only half of those that took the medicine completed the course, took the whole course. So I think that, I know as a doctor, I'm always struck, I'm giving out all these medicines, I'm thinking it's my own magical thinking. I'm thinking they're going to go and fill them and take them. And I should know better, because I know when I get medicines myself, I take them till I feel pretty good and then I stop. Good communication will get patients to take their own medicines better. They will get better faster. They will sue us less often. And they will recommend the doctor and the managed care group to their friends. Now, managed care is really important to us because, as Nigel has pointed out in years past, how medicine works reflects on how the culture works. It's a $1 trillion a year business, 18%, 20% of the GNP. We can't ignore the fact that it's so important that we need to do this right, and we need to make a good pluralistic system. Only a stubborn 3% of American adults resist going to the allopathic or osteopathic doctor in their lifetime. Do you know what's more dominant? What's a more dominant system? Not that many people go to their lawyer. Not that many people go to their church. So we have incredible dominance of this system. More than 80% of our population sees the doctor in a given year. We can't mess this up. Patients make more than 1 billion visits to physicians' offices every year. Doctors make still another 400 million visits to patients in hospitals or nursing homes. 20% of patients with acute problems get their advice over the phone. And I know for myself, there's many days when I make 20 calls a day to patients. It takes about an hour. In America, there are about 600,000 medical practitioners, 1.5, maybe more, million nurses, 2 million now, 150,000 pharmacists, 150,000 or so dentists, and on and on. Big group. The size of clinic rooms, though, has diminished. I think so much can be seen by the mechanical aspects of our lives. I was saying to our small group today, if you drive into any town in America, you see the hospital has this nice big Frank Lloyd Wright edifice, and the school is like this one-story brick thing. It was built in 1950. Despite the capital outlay, though, physicians, like all people in the 90s, feel the downsizing. So the size of a clinic room has diminished from 16 feet by 20 feet back in 1850 to 8 by 10 feet today. It's really half the size it was back in the 1850s. And in big clinics, multiple doctors use the same office. So you never see Dr. X's picture of herself and her diplomas, her family's pictures, special books that she has, trophies, her knickknacks. You don't see that. You just go into a sterile room. Now, it's interesting, I noticed that pictures of pediatric patients are very common, especially pediatric dental patients. And in the adult setting, we never have pictures of our patients. You have an incredibly rare time to find pictures of adult patients. The position of the desks and chairs in a room have importance in communication. It used to be that the doctor's chair was an executive swivel, and the patient's chair was kind of a straight back, little plastic thing. But now that's changed a little bit, and I just challenge you to, when you go to your doctor's office, take a look at that. Now, the mean wait in a doctor's office, whether managed care or not, managed care is trying to cut this down, is 30 minutes. And a reduction in waiting time signals a more egalitarian approach. So the higher status patients, the higher status they're viewed, the less they have to wait. Or even a shift in relative status. So if the patient is the vice president, I will go to see her. If the patient is the sports figure, if he's on the Milwaukee Bucks, Chicago Bulls, I will go to see that player at his house, right? He doesn't have to sit for 30 minutes in my waiting room. So it's a status thing about the time issue. Now let's look at how this discussion works. The actual discourse of medicine works like this, according to Mischler. There's a structural unit of discourse, which is a set of three utterances. The physician has a question. The patient has a response. The physician assesses and asks another question. So let me give you an example. There's usually a lot of, you'll have to pardon this non-lexical, there's a lot of like hemming and hawing in real speech. So here's a real discussion. Doctor says, does drinking make it worse? Patient. Yes. Especially the carbonation and the alcohol. Doctor. How much do you drink? So the doctor there is making an assessment about shifting from gastritis to alcoholism. Physicians control the organization and content of interviews, the kind of voice of the interview, and patients' concerns are kept down in a kind of separate area. Not only does the physician ask almost all the questions in a medical interview, but these questions are almost always in the voice of medicine. How much do you drink? And therefore move the discourse consistently away from the topics of the patient's life world. Now this is a business issue. The patient's talking about his or her problem, and we're writing things down about the number of beers he drinks. Now, I know that's important, but it's interesting because that's not what we're talking about. Does drinking make it worse? Yes. The author of this Mischler, of this analysis says, medicine is a dialectic between the voices of the life world of the patient and of medicine, and it's this conflict and struggle. It's almost as if you're trying to write a poem, and the doctor's writing the poem in one language, and the patient's writing in another. So the patient's saying, I feel like I'm having fullness in my stomach, and the doctor's thinking, the cancer is spread. I wonder if he's losing weight. Now, what's the physician's responsibility in this? I think it's moving toward a third language. The patient metaphor is, say, my chest hurts. Maybe it's my heart. It hurts all day long. And the doctor translation is, this chest pain is atypical. A typical chest pain is probably not cardiac. It's either musculoskeletal or GI pain. Now, the managed care language is, this patient's symptoms do not warrant expensive cardiac testing. Only symptomatic measures are authorized. The spoken language is the most important tool we have. And one of the masters of this is Eric Cassell. I'll just give you an example he uses. Patient, I want to know exactly where do I stand with this cancer. When can I be up and walking around and go home? Doctor, that depends on what happens now. You're obviously now getting better, getting stronger. Patient, I see. Doctor, a lot of it depends on how you feel about it. A little stronger than good, fine. Because while I cannot make that liver better, here or at home, I can help you keep in control of your situation. So, patient, can you control the liver by medication? Doctor, yeah, no, just listen to me. Listen to me carefully. All right, I cannot make that liver get better. I can keep it from getting worse. I can only keep you on top of things for as long as that liver holds out for you. Cassell notes that he does for this patient what language allows a person to do for themselves. Take that diseased liver and put it over there, that liver. Objectifies it. Keeps you in control. You're getting better, keeping you on top of things. Given an ominous reality, he says, we can still work in the world of language. Now, in the Christian realm, I think we can go even one step further, pointing out that God is in ultimate control. How much better it would be to say, or how much one more step we could take saying, I can't help you totally stay in control, but I think God can help here, can he? Well, managed care has to address this. And managed care really risks another level of translation because it risks viewing the patient as a commodity. And people are not foolish. People are not stupid. They can tell they're being treated like a piece of meat rather than a person. So if they really feel that way, they'll reject managed care. And I think a good managed care plan wouldn't do that. William Hurt's character in the movie The Doctor says, as he fires his rude radiation therapist, he says to her, someday you will be a patient too. We all get to be patients sometime. And when I used to be a doctor like you, I hated patients like me too. Interestingly, he chooses a religious doctor, a devout Jew, to be his surgeon because he knows he can trust this person. Trust counts because today managed care plans are increasingly structured with a profit motive, and that brings in the question of trust to us. The marketplace rewards efficiency, and it rewards, of course, making money, and of course, we sometimes don't trust people that make money. Now, in light of all these changes, physicians and nurses need to recognize their own limitations and vulnerability, and I think it's great to have a meeting like this. We need to respect ourselves as professionals, and perhaps what I fear most about managed care is that it will diminish our sense of professionalism and morale, nurses and doctors. I think particularly nurses because of the downsizing of hospitals and clinics, the loss of nursing. And we don't want that to happen, because we won't even be able to hear our own language in a little while above the language of the strict business. And I don't think that's what our patients want. I really don't. I don't think they want you to even think of their insurance when they finally get in that room and close the door. I don't think they want you to know what their managed care plan authorizes. I think they want you to figure out what you should do for them and say it to them. And if it's not what managed care likes, then at least you're both in the same boat. Solutions, well, I think we need to preserve the language of medicine. It's the essence of our work. I think it is, because it's humanly based, it has its flaws. It's not a biblical language. But I think that's something we can do. I know that Dr. Koop often objects to the word provider and as a real problem because it's not, you don't go to medical school, you don't go to nursing school to be a provider. Where I come from, a good provider is someone, who brings home enough money on Friday night to feed people. I don't think managed care is a fad, but I think it's just a phase. The passing of this phase will be even more certain if managed care takes itself too seriously and doesn't take the patient seriously enough. The gripes of the patient, the sense that the patient has that this is low-tech, low-touch. And if managed care fails to remember that managed care executives will be patients too someday.
It's my pleasure to introduce to you Dr. Harold Brown, who is the Chair of Ethics and Theology here at Trinity Evangelical Divinity School, where he's a professor of biblical and systematic theology. He has 4 degrees from Harvard. He co-founded the Christian Action Council, one of the leading evangelical pro-life action groups, with Dr. C. Everett Koop. He's director of the Center of Religion and Society at the Roxford Institute. He teaches in the International Seminar on Jurisprudence. He's published widely, both articles and books. It reminds me, his topic as a patient a few years ago, I got sick in Thailand and didn't speak the language, ended up in a hospital there. It gave me a whole new view of medicine, and I'm sure being a patient gave him a whole new view of ethics. Dr.
Brown. Thank you. After a good, solid academic discourse, I'm afraid that now you will be exposed to sort of a series of horror stories, but they may be in some ways more entertaining. I come from a medical family. My father was a physician. My grandfather was a country doctor in Florida, and although I didn't know him because he died before I was born, My father told me he never went out in Florida weather on a call without a coat and tie. I don't quite know how they did that. That seems to be one of the greater accomplishments of the previous generations. But in my own case, although I've had a fair amount of science background and have a fair understanding of anatomy and other such things, I have also had a perhaps unreasonable reverence for the representatives of the medical profession. And consequently, I have tended to entrust myself very largely to what they told me rather than to some of the things that I might have suspected or thought myself. Now here at Trinity Evangelical Divinity School, we did have earlier a more standard type of insurance program which permitted the patient to seek out his own physician or her own physician and in general paid rather well for whatever services were needed. In 1992-93, we went on to a new and more efficient HMO type plan, and the HMO type plan that we went on had 3 stages. It had a rather simple stage, a more complicated stage, and then finally the most complicated stage, which was also the most expensive. We chose the 3rd stage, which gave us the greatest freedom. But one of the things that it required us to do was to choose our family practitioner from a number of local people. We live fairly far away from Trinity, and our family practitioner out there was not in the system. So we were able to go back to someone whom we already knew, a gentleman just slightly older than I, so obviously of a good number of years' experience in medicine. And in the very first year that we were in this program, I discovered some rather peculiar neurological symptoms. I could describe them, but went in they seemed to be associated with a sinus problem. I went in to see this gentleman and was told that it would be a good idea to have a CT scan. I went in for the CT scan and was told I probably had a sinus infection, so something was prescribed for this, and then I was sent home. Now, the condition did not get worse, but it didn't really get better. And since this program paid for an annual physical, I had been in the habit of going into doctors only when it seemed that something was wrong, but went in for the annual physical and, of course, made the complaints again, and was told, well, I even made some suggestions. I thought perhaps something had happened to the trigeminal nerve because I was getting peculiar sensations on the side of my face. Perhaps facial neuralgia. No, the physician said, that's not possible. I really don't know what the cause is, but probably associated with your sinus infection. And this went on for quite a long time. The CAT scan was in 1993. In 1995, for the first time, I had a bit of double vision. Now, I know that one often associates double vision with a brain problem, and so that thought occurred to me, but I, being perhaps a bit apprehensive, didn't say to the physician, do you think I have a brain tumor? I just told him about the double vision. And nothing much. Well, I sent to an ophthalmologist, whom I also told about it, and the ophthalmologist, whom I'd seen before, did some testing and said, well, you have a palsied 6th cranial nerve. Well, the double vision did not really, I could clear it up with prismatic glasses, at least clear it up for a time. Then the eye began to deteriorate even more, and so I reported this to the ophthalmologist, and he said, well, perhaps you have diabetes. This was excluded by the primary care physician who had just given me a complete physical, and I think indeed it was to be excluded. But after continual complaining about the eye and funny facial symptoms, which no one could really identify, I was told by my primary care physician, who is now replaced by his associate, that, well, I have marginally high blood pressure, and probably that's the cause of these neurological symptoms. Now, that sounded strange to me, but I didn't pursue it, to see, well, is it really that moderately high blood pressure causes strange sensations in one side of the head? Surely these people know. I mean, after all, they have an MD degree, or in the case of the other individual, a DO degree, and seeing them on a rather regular basis and continuing to complain. Finally complained so much about the eye that he sent me to another ophthalmologist, also in the plan. This chap examined me, discovered that the eye worked all right, but of course it didn't look in the right direction, and told me I had a weak sixth cranial nerve. So I asked this physician, why is it that it has suddenly developed? And he gave me an answer like this. He said, well, you probably had it for a long time, but as you're getting older, you know, these things begin, you fail to compensate for it. Now, I've been getting this story also from the other physician. I complained about this. They said, well, you're getting older, you know, you have to expect this sort of thing. Well, I'd never gotten older before, so I didn't know whether that was... I didn't really know whether it was normal or not, but again, sort of trusting, you know, in the medical profession, took this as long as I could. And finally, when the eye was essentially blind, I began to make such a fuss about it well, I said that I would like to go and see someone at the University of Chicago or someone who was perhaps somewhat more specialized, and was told, well, you can do that if you want to, that's up to you. I did go to see my earlier ophthalmologist. He told me to do various things, including seeing another physician and getting an MRI, and went back to the primary care physician saying, I need a reference for an MRI. He said, no, you can't, I will not give you any, or he didn't actually tell me himself, his secretary told me, Dr. So-and-so says he will not refer you for anything. So needless to say, changed physicians. The next physician did give me the recommendation, and lo and behold, there was a very, very extensive problem. This proved to be a most alarming situation. For the first time I saw the extent of it, and it was really quite extensive. Fortunately, in the providence of God, I was then placed in telephone contact with an expert physician who was actually here at the conference, and he spent about half an hour talking to me about the various possibilities. Now, I had never met this man before. He was a friend of mine, and I asked him a question, which is not the sort of thing I normally ask anyone, whether an attorney, a lawyer, doctor, interprofessional relationship. I said, are you a Christian? He said, oh, yes, I am. And I later discovered from various sources, and indeed from his presence here, that indeed he is. I did feel, you know, a certain different type of confidence in this gentleman and in what he told me, and he recommended an eminent surgeon. The eminent surgeon examined the case and indeed decided to remove the tumor, which he did, and I think he did a very, very excellent job with it. He also removed, by now, the eye, which was doing no good, and that was a bit unpleasant, but not the surgery, but the thought of it and the consequences. Then this chap decided to, well, he went on vacation, which was quite normal for anyone, I suppose, and left me in the care of a fellow who did not know me, a fellow being an actual title of a position at the hospital. And after the surgery, my condition deteriorated. And so first I talked to this fellow by phone about it, and he didn't seem concerned. Then my wife began to call him when I could no longer communicate properly. And finally, two MDs who were friends of ours who were at the house called up and said, you've got to do something about this chap. You know, things are really not looking good. And he still says, normal post-operative problems, don't worry about it. Well, the following day, this was the 30th of December, the following day, the 31st, it was obvious that things were really bad. And so I was taken off, I don't remember it, but taken off to Northern Illinois Medical Center, which is a small local hospital. And there, who should appear but my previous non-HMO GP, who brought his influence to bear and succeeded in getting me transferred back to the major hospital where I had been. All of this happening, you know, without my knowledge at this point, because it seemed that I had a rather substantial cerebrospinal fluid leak, and in fact had leaked out almost all the cerebrospinal fluid. And so I was probably rather close to the end of my life at that point. And in the hospital, I was put on the neurological ward, given no particular treatment except a lot of antibiotics. But they're told to lie flat, not to move, and I did that. And after a few days, the leak closed up, and a few more days, I was able to go home. Now, there's several interesting things about this. One of them being that the treatment in the neurological ward was infinitely more compassionate than in the ward in which I had been earlier. I don't know if that's a characteristic of hospitals in general or this hospital. I might also say that one rather striking thing happened. You'll hear I'll see her at Coop tomorrow night, I'm sure. And after I'd been in the hospital the second time, about a week, one of the attending physicians called me up and said, do you know Dr. Coop? And I said, oh yes, we work together and so on and so forth. And she said, oh, that's a relief. This guy called me up and said he was Dr. Coop and asked about your case. And I gave him all the information. And so I don't think that will do any harm. But one of the curious side effects of this was that I got a lot of very favorable attention in the hospital after that, and various physicians would come around. Now, friends, I think it is unfortunate, to think that the vast majority of people do not know Dr. Coop. And it is a little strange to think that your care, might depend on this type of influence, which you mentioned earlier. In my case, I don't think it really made any difference because the fundamental problem had already been resolved. But it was rather interesting to see the deference that was then accorded me, whereas before I'd been treated all right, but I was getting some extra special attention. Well, all of these things, I think, go to show that one of my initial ideas was mistaken, namely the idea that one could simply trust the physicians to do the right thing. My earlier primary care physician had actually given me a clue, which I didn't follow, and I think I'll conclude with that. Very early on, I asked him about a referral to a dermatologist because I had a small keratosis that didn't look very good. And he said, no, he said, I can't do that because of the fact that it would be purely cosmetic, and I think the insurance company wouldn't like it if I recommended for cosmetic things, did that too much, I would begin to be in difficulty. And there were a couple of other signs like this, that this chap, who is an older physician, was really looking to the way his assignments and referrals would be regarded. And of course, the last word from this office, I won't refer you for anything, I think was rather striking. I don't know how many people have this kind of experience. I am grateful to Dr. Ye, who's here, for the advice that he gave me. I am grateful to Dr. William Panji for the surgery that he did on me. And I'm grateful to the many nurses and other physicians at the hospital who were extremely courteous and compassionate. But I certainly am not grateful to the people that I dealt with first of all and who could have discovered this situation a number of years earlier. So what I've learned from that, I guess, is that it's in the managed care situation, it's not necessarily a good thing simply to trust your physician. And probably if you get any signs like the ones I had, of unwillingness to refer, you should think about changing before the situation becomes desperate. Well, I've gone on a little longer than I intended to, but you have the abridged version. The unabridged version is even longer. So thanks for your attention.
It's my pleasure to introduce to you Barbara White. She is the Assistant Professor of Nursing at Regis University in Denver, Colorado. She is now working on her doctorate with a dissertation in the moral leadership of nurse executives, which would be a fascinating paper. She teaches leadership and management concepts, healthcare ethics, community health, health promotion, and spiritual care. She does consultation to Health One, a nonprofit affiliate of Columbia Presbyterian St. Luke's Medical Center in the area of education, research, and community philanthropy. She's been very active in the Nurses Christian Fellowship and very involved there in the state of Colorado as well as on the National Council. So it's a pleasure to welcome her through the microphone.
Thank you. Last Thursday morning, I was talking to my friend and colleague, Sue. After 18 years of critical care experience, Sue recently left her position as a nurse manager in acute care services in one of the largest hospitals in Denver. Why'd you leave, Sue? I asked. You're probably one of the best nurse managers I know. Your expertise in critical care is outstanding. You're a leader in your field. Your staff respected you. I left because I could no longer sleep at night, she told me. I had always prided myself in providing the best possible care for my patients And when I became a nurse manager about 7 years ago, my goal was to provide my staff with the best environment possible so they too could provide quality care. But in the last year, we were forced to drop patient care hours significantly. Unit secretarial support was no longer there. I couldn't get administration to listen, and they wouldn't respond. I had never asked staff to take a patient care assignment that I myself couldn't handle. Suddenly, I was asking the nursing staff to do what I knew was unsafe. Ethically, I could no longer do the job. I had to resign. Change within the healthcare industry is placing growing pressure on the over 2 million registered nurses in the United States. From staff mix changes to staffing being supplemented by nurse aides, to overall restructuring and downsizing in healthcare. Job security and job stability for registered nurses are a thing of the past. Healthcare reform is changing healthcare financing, care delivery, resource allocation, and patient-caregiver relationships. The focus addresses issues of cost, access, and quality. 3 simple concepts that really become complicated when they're intertwined in the complex array of financing arrangements and delivery mechanisms and market forces, professional interests and government structures and political realities. Transition is difficult, and no one is more acutely aware of the real issues than the nurses themselves. In an attempt to hear their voices and to relate their stories to you tonight, I recently surveyed more than 50 registered nurses in a variety of healthcare settings. I asked them just one question: how have the changes in healthcare impacted your nursing practice? The nurses experiencing changes in healthcare are speaking strongly to very high standards, to deeply held convictions, to realistic frustrations, and to intense emotions. Nurses are struggling today with balancing care with limited time and resources. Staffing issues are intense, and patient safety is of utmost concern. Diane, an expert ICU nurse, stated, "Last weekend we were short-staffed, and we weren't able to get any pool nurses. The unit was full, and the charge nurse requested that we divert any other new patients to other facilities. But administration refused and sent us 3 more patients. One of my patients cored and didn't make it. The family's very angry, and they'll probably sue. I may lose my job. I feel terrible. What should I have done?" Another expert ICU nurse reports, "Our staffing grid is the standard used to staff the unit no matter what the acuity of patients. It's supposed to keep us in budget. It's just fine, unless we have open hearts. The first few hours after surgery, these patients need one-to-one nursing care management." Now, our administration's pretty strict about the grid. When we complain about patient safety, we're told it should work, just triple up on your other patients. We staff nurses feel this is unsafe, especially after 2 in the afternoon, when we also have to clean the rooms because environmental services have been cut. Patients have extubated themselves, climbed out of bed, and gone into VTAC while nurses are cleaning toilets. Nurses in other settings are also concerned about staffing issues. A psych nurse states, "New graduates don't get any orientation anymore. Recently, we had 2 new graduates hired on a unit where all the expert nurses had recently resigned because the company cut back full-time nursing staff to 24 hours a week." A clinic nurse reports, "We recently had a physician and 2 nurses leave, but we've been told we can't replace them." And finally, a med-surg nurse states, "Sometimes it's truly a night for survival of the fittest. Now, I'm a seasoned nurse, and I know how to prioritize, but now I must literally prioritize who gets seen and who's on autopilot. I can't be there for patients anymore, and that's what hurts the most." Nurses today are finding restrictions and limitations on the care they can provide. Nursing care frequently ends before patients' needs are met. Sometimes nurses have to choose between insufficient care or no care at all. Another nurse states, in the past few years, I've seen resources decreased for our psychiatric patients. Patients without insurance have less or no treatment options. Truly, only the most severely ill get admitted. We joke that there must be blood on the floor for some insurance companies to authorize admission for suicidal patients. Many are discharged into the streets or to shelters. Some end up going to jail. A clinic nurse reports that she has 10 to 15 minutes only to see each patient, and to make matters worse, she's now being timed and given 3 to 5 minutes to answer phone calls and answer patient questions. Another nurse is concerned about the rehab that her stroke patient isn't getting because the insurance company won't pay for it. And a home care nurse states, as a nurse specializing in non-surgical management of urinary incontinence, I have had outstanding results with a bladder training program. In 4 to 6 visits, I'm able to instruct and enable people to learn and incorporate new behaviors into their lifestyle. 8 out of 10 of my patients have had great outcomes and new hope in life. But now with managed care, I get 2 visits. I've written letters, made phone calls to people making decisions, trying to give them rationale, telling them it's going to save money and it's going to avoid unnecessary surgery in the long run. There's so many hoops I must go through that by the time I'm blessed with visit number 3 and maybe 4, the patient's forgotten everything I taught in visit 1, and I have to start all over again. Nurses are dealing with situations that generate feelings of discouragement and fear, abandonment and anger. One nurse states, I've not had management accessible to me. They're so busy in meetings, I rarely have supervision at all. A nurse in surgery. I've had to stand alone many times when patient safety is concerned. Just last week on our unit, there was an emergency surgery scheduled on a high-risk infant at 5:30 at night. There was no backup help. The RN asked me to stand by, and I stayed with much resistance from management. Now, I know money was a decision maker, but when a coworker feels there's a need for me to stay, I'm going to be there. Another ICU nurse working with aides instead of RNs expresses anger as she gives example after example of aides filling in for nurses, passing medications, and carrying out physician orders. And finally, Vicki, a rehab nurse, states, I find that the changes in healthcare have impacted the personalization of nursing. There's decreased time to spend with patients' emotional and spiritual needs. It takes time to listen to the patient who's over 80 years old. They don't speak very fast. It takes them longer to form their ideas. It's so very rude to rush through care. I find it very difficult to know the whole person anymore. Sometimes really all the patient needs is for someone to listen, and I could skip the narcotics. Could their pain be taken care of by diversional methods? A young patient with multi-trauma lies over there in the bed and runs the tapes of his life and he can't cope, and the nurse has no clue about the real issues. I find that the decreased time spent with patients greatly impacts my desire to treat the human spirit. Several trends influencing the delivery of health care and the role nurses play today are summarized in 3 key significant trends. First of all, healthcare restructuring. Nurses have traditionally been service-oriented professionals. They've been patient care driven, not bottom line driven. But changes in hospital structures and the business of healthcare are changing the way nurses deal with patients. As a result of hospital consolidations and mergers, nurses who were once employed by small private hospitals are now finding themselves working for national chains or for regional multi-system corporations. Many hospitals are now contracting for outside services to provide management, education, and even at times clinical services. Other hospitals have entered into arrangements in which 2 or more organizations are going to share staff and facilities. No matter what the arrangement, the objective is the same: reduce cost and increase productivity and profit. The second trend is workplace redesign. Nurses have been functioning under a total patient care model. Now they are returning to a partnership model where they must delegate tasks to an aide. Safe delegation has become a critical issue. In some instances, unlicensed aides are being used to replace rather than augment nursing care. Nurses are required to work in multiple specialty areas and sometimes do not have adequate training. Patient acuity and earlier discharge characterize the sicker and quicker reality of patient care. Workloads have increased, computer documentation has expanded, and nurses are required to perform duties for other departments in addition to care measures, which then limits the time they have to spend with patients. A third significant trend is career retraining. In the early 90s, over 2/3 of all nurses worked in hospitals. It's anticipated that by the year 2000, less than half will work in acute care facilities. With fewer hospital admissions and shorter stays, more health care is being provided in outpatient settings, such as homes and ambulatory care settings and extended care facilities. Greater emphasis is being placed on health promotion and disease prevention. Nurses are finding increased job availability and career enhancement opportunities in these community-based settings, but they are needing to be retrained and retooled in order to be competent. In today's healthcare environment, novice and expert nurses alike are having to cultivate very unique workplace skills in addition to clinical expertise. According to Leah Curtin, the clinician's ethical focus in today's healthcare has changed from that of patient advocate to responsible steward of society's resources. One nurse describes it this way: we are moving in nursing from patient advocacy, giving the patient every service needed, to figuring out what the patient really needs, then providing the right care in the right time, in the right setting, at the lowest possible cost. Clearly, the challenge for nursing today has become more business-minded, more effective leaders, and more discerning employees. Nursing's response to the change in healthcare is real varied. Some nurses, too timid to speak out about unsafe conditions and convinced that their jobs are on the line, choose to respond by just quiet compliance. Others who see no way that they alone can penetrate management's wall of denial are turning to unions to protect themselves and their patients. Some suggest that nurses should respond politically through the professional organizations. Others suggest the educational imperative is the solution. Some nurses rationalize, others compromise their values, and some nurses, like the one I mentioned early, stand firm and do not compromise values and may change employment. The response of nursing to the changing healthcare environment must incorporate the value of nursing's unique contribution to patient care. A recent study published by the American Nurses Association confirmed the positive link between adequate nursing care and patient outcomes. RN staffing was significantly related to shorter lengths of stay and to morbidity indicators for preventable disease. Over a decade of research shows clearly that when there are more RNs present, patients experience fewer complications, they have lower hospital readmission rates, and fewer deaths. Now, in the long run, that means overall lower healthcare costs. Indeed, the system is changing. Nevertheless, healthcare reform does not justify abandonment of the patient. Healthcare policy is far too important to be left to business people and politicians, and health services are too vital to be left to contracts and protocols. We all need to be involved. People need to know that they can find help when they need it, and that the health care they receive will be competent and compassionate, available, and affordable. Now, as Christian nurses, God's purpose for our ministry in healthcare is quite different than the world's perspective. In these chaotic times, God is truly calling us to maturity in Christ. In Ephesians 4, Paul, speaking of the spiritual gifts given by Christ to prepare God's people for works of service, really commands us to become mature and to speak the truth in love. We are called to present the living and true God to a suffering and lost world. The changes in healthcare are exerting tremendous pressures on nurses, creating feelings of fear and anger, compromise and discouragement. But as Christian leaders, we must help other nurses to develop a Christ-like ethical system to hold fast to their values, which will allow them to live fearlessly, to redeem their time, and to advance the cause of Christ in the healthcare environment. In Acts 17, Paul really approached the chaos of his day and illustrates how we are to be well informed on the issues. We're to be persuasive and compelling in our speech and to be spiritually sensitive to our environment. God, through the indwelling power of his Holy Spirit, really assures us that he's involved in every detail of our lives. He knows the issues and the problems in healthcare. But he is at work in the world, and he invites us to become involved with him in his work. We are all being called to moral leadership in these changing times, and we need more today than ever before, the discernment, the boldness, and the faith that comes through our faith in Christ. Christ himself told us that in this world we were going to have trouble, but to take heart, to be encouraged. He has overcome the world. And as Esther 4:14 says, and who knows but that you have come to royal position for just such a time as this. Let us rejoice in the challenge. Thank you.